I'm going to give an overview of focal therapies from a urologist perspective. Let me just screen share and we'll start the talk. So this is an overview of image-guided minimally invasive focal treatments. I have no disclosures. We're going to review approaches in the urologic perspective on emerging data on patient selection and outcomes of focal therapy. This is just a good paradigm that demonstrates from a workshop at the Food and Drug Administration the entry criteria for a proposed randomized trial to evaluate new technologies, that is, men eligible for active surveillance, and a primary endpoint of local progression by a biopsy, secondary endpoints of salvage therapies, that is, either surgery or radiation therapy. And we'll see that for most of the real-world evidence that I'm going to review, the sweet spot appears to be men with intermediate risk prostate cancer. The first study is one from the University of Miami in which they performed high-intensity focused ultrasound on 52 men. You can see that the majority of these patients, 60%, had intermediate risk or Gleason 7 disease. About a third had low-risk disease. And in terms of biopsies that were performed at 6 or 12 months, approximately two-thirds of men underwent these biopsies. And you can see that overall, approximately 30% of men were found to have significant cancer or recurrence. And when you look at the location of the recurrences, they tended to be at the apex, either in field or out of field, as designated by the X or the plus sign. And this may go back to the known occurrence of greater recurrence on biopsies because of high-intensity focused ultrasound. I think most providers try to avoid too much heat there at the apex at the potential risk of incontinence. Next, we'll look at a series from the Sunnybrook group in Toronto. This is a group in which they treated with high-intensity focused ultrasound largely men with Gleason 7 disease, and you can see much fewer men with low-risk disease, only 11%, and almost 80% of these had Gleason 3 plus 4, 4 plus 3 equals 7 disease. And the roughly 87 men, or half of the cohort that had a biopsy at a median of 13 months after treatment, the number of men who had Gleason 7 or higher cancers was 61%, while overall 71% had residual prostate cancer. A multivariable analysis was also performed, and this demonstrated that men with greater tumor volume, those with a medial tumor location versus a lateral tumor location, and the log PSA, those factors were associated with a higher risk of recurrence at biopsy. In terms of the functional outcomes, you can see that a very low proportion of men, 1.4% and 2.2%, had significant deterioration of either urinary continence or erectile function, respectively. We now turn our attention to a French series, a larger series of 309 men overall. 190 of these men underwent high-intensity focused ultrasound, 119 underwent cryotherapy. You can see that this is a cohort of largely treatment of low-risk prostate cancer, with roughly 30% of men having Gleason 7 disease that underwent therapy. Of these men, you can see that the recurrence rate, again, overall, for both modalities was around 39%. For cryotherapy, it was 45%. For HIFU, was 36%, although this was not statistically significant with a P of 0.1. In terms of looking at multivariable predictors of failure, you can see that men with a Gleason 7 versus 6, or 7 or higher versus 6, were 2.4-fold more likely to experience recurrence. And those men with a post-focal therapy PSA nadir that was 2.5 or more were also 2.2-fold more likely to experience failure. Now, looking at our own series of in-office partial gland cryoablation, and this is an ideal 2A exploratory study. So this is 55 men who underwent the partial gland cryoablation under local anesthesia. There were 43 men with at least 6-month follow-up. However, 8 of these men were non-compliant with the study design to get a biopsy. You can see that of the 43 men, 13 had the presence of clinically significant cancer. And then of these men, you can see that some underwent surgery, radiation, some underwent repeat partial gland ablation, and also those that had a lower amount of pattern 4 were comfortable with active surveillance. Patient selection-wise, you can see that this is, again, largely a series of grade group 2 and 3, or that is 7s. We had approximately 18% of men who had higher risk grade features that opted for focal therapy. in terms of the recurrence rate that I mentioned earlier, assigning a percentage of this to this is roughly a 37% likelihood of finding clinically significant cancer on a biopsy at least 6 months after cryoablation that was MRI guided. The urinary and sexual function, consistent with the other studies, remained relatively similar to pretreatment. And when we look specifically at sexual function using the EPIC clinical practice, where a higher score is associated with a worse outcome, you can see that there's actually a little bit of improvement that occurred between months 4 and 9, although overall there was not even a one question category change when you compare it to baseline, and the same held largely for urinary control as well. Adverse events, you can see that urinary tract infections that required intravenous indication, that is IV antibiotics, comprised largely most of the grade 3 complications. There were men for whom medical therapy weren't helpful, that is Viagra, Cialis, or Levitra. Therefore, some of these men underwent injectable therapies, and those were captured as grade 3 complications. I'll just put a plug in for the comparative effectiveness work that we're doing in evaluating focal therapy on a population-based level. We call this the PC concept. It's been funded by PCORI, the Patient-Centered Outcomes Research Institute. This is a $3 million+ grant that we're going to prospectively capture men who are undergoing treatment in Los Angeles County under the supervision of Ann Hamilton, in New York State under the supervision of Maurice Shimura, for the SEER regions, National Cancer Institute tumor registry regions. Andrew Vickers is our study biostatistician. Art Strakian's a close collaborator with this and the FDA work that I showed earlier. And so in summary, a significant proportion of men, we've seen 30 to 60%, have biopsy-proven cancer on their follow-up biopsy, and a significant number of men overall do not get a biopsy. So that's concerning for perhaps hidden risks and long-term follow-up in terms of missed cancer or potentially missed window of curability if these men don't get a biopsy at some point. Functional outcome preservation certainly is better than whole gland treatments such as radical prostatectomy that the urologist offers, with a 1 to 2% risk of significant deterioration of urinary and sexual function respectively. However, I'd also mention, although we didn't get into this in the interest of time, there's significant challenges for accurate biopsy and surveillance. Firstly, because PIRADS has not been validated in the post-focal therapy setting. And secondly, there's significant volume changes and or orientation shifts of the prostate where the cancer was before the focal therapy with the MRI-guided biopsy. And trying to track that area, despite some of these volume and orientation changes, may prove difficult, and greater work is needed in this area. Thank you for your attention.